Welcome back to the podcast, everyone. I'm Dr. Khan, and I am joined today by the ever-precise Dr. Sarah. Today, we are zooming in on a small but incredibly high-stakes piece of real estate on the hand, the anatomical snuffbox. Dr. Sarah, I've always thought of this area as the diagnostic gateway for the wrist. If you miss something here, your patient is in for a world of hurt later.
That's very true, Dr. Khan. From a board perspective, the anatomical snuffbox is a classic favorite because it combines complex tendon boundaries with critical neurovascular structures. If you're a student, you need to know exactly what forms the borders and what lies in the floor. It's high yield 101.
Exactly. Okay, let's set the stage. You've got a patient who just fell on an outstretched hand, the classic fouche injury. They're pointing to that little triangle at the base of their thumb. Before we talk about the why, Dr. Sarah, remind us of the what. What makes up those walls?
Let's be precise. The lateral border, that's the one closer to the thumb side, is formed by two tendons, the abductor collisus longus and the extensor pollicis brevis. The medial border is formed by just one, the extensor pollicis longus. A quick memory tip, the longest tendons are on the outside of the group. If you hitchhike, you can see these tendons pop right out.
I love that. It's like a little canyon. And sitting right at the bottom of that canyon, acting as the floor, is the most important bone in the wrist for clinicians, the scaphoid. Now, why does this matter clinically? Because if you have tenderness in that snuff box after a fall, you have to assume that scaphoid is fractured until proven otherwise, even if the x-ray looks normal on day one.
And the boards love to ask why we worry about the scaphoid specifically. It's all about the blood supply. Dr. Khan, use one of your analogies here.
Think of the scaphoid's blood supply like a one-way street that enters from the wrong end. The blood vessels enter the scaphoid at the distal end and flow backward to the proximal part. If you fracture the waist or the middle of that bone, you've basically put up a roadblock. The proximal half of the bone gets zero blood and it dies. That's avascular necrosis.
Precise and accurate. Now, we can't talk about the snuff box without mentioning the contents. The radial artery passes right through it, which is where you can actually feel a pulse if you press carefully. But for today, I want to focus on the nerves, specifically the superficial branch of the radial nerve.
Ah, the sensory hero of the back of the hand. Why does this matter clinically? Well, if you have a patient with a wrist injury or even a tight watch or handcuffs, they might complain of numbness right there. But Dr. Sarah, help us differentiate. Where exactly is the radial territory?
The superficial branch of the radial nerve provides sensation to the lateral 2/3 of the dorsum, or back, of the hand. Crucially, it covers the posterior surface of the lateral 3.5 fingers, but only up to the nail beds. The tips of those fingers are actually the median nerve's job. But for the boards, if you see sensory loss in the web space between the thumb and index finger on the back of the hand, that is your classic radial nerve test site.
That's a great distinction. It reminds me of a case in our text involving a 64-year-old woman who fell down the stairs and dislocated her shoulder. She didn't just have shoulder pain, she had massive sensory deficits. She couldn't feel the back of her arm, her forearm, or that lateral half of the back of her hand.
That case is a perfect example of a double hit to the nerves. A subcoracoid dislocation can damage the axillary nerve, which explains the loss of the rounded shoulder shape, but it can also stretch or compress the radial nerve as it exits the brachial plexus. If the radial nerve is hit high up at the shoulder, the faucet is turned off for everything downstream.
Exactly. If the nerve is damaged at the shoulder, you lose the triceps, you get wrist drop because the extensors are gone, and you lose that sensation in the snuff box area. It's a total shutdown. When you perform a thorough exam like this, checking every sensory branch, you really become the doctor of choice for that patient because you're catching the subtle details others might miss.
Speaking of subtle, let's look at the anterior interosseous nerve for a second. Students often confuse it with the radial nerve because they both deal with deep structures. But remember, the radial nerve is the king of the posterior compartment. If you can't extend your wrist, think radial. If you can't make the OK sign with your thumb and index finger, that's median nerve via the anterior interosseous. Great point. Back to our snuff box. One thing I always tell my residents is that when you palpate the scaphoid, don't just poke the skin. You have to have the patient ulnar deviate their wrist. This moves the scaphoid out from under the radius so you can actually touch it. If they jump off the table in pain when you do that, you've got your diagnosis. And from an exam perspective, remember that the superficial branch of the radial nerve is sensory only. If a question describes a patient who can't feel the back of their thumb but has perfectly normal strength in their finger extensors, the injury is likely distal, like a compression at the wrist, rather than a high radial nerve palsy.
It's all about the level of the lesion. To wrap this up, if you're looking at the hand, know your borders. APL and EPB laterally, EPL medially.
Know your floor, the scaphoid, and know your nerve, the superficial radial nerve for the back of the web space.
And never forget, tender miss in the snuff box plus a foosh equals a scaphoid fracture until proven otherwise. Watch out for that avascular necrosis.
Perfect. Thanks for the precision, Dr. Sarah. We'll see you all next time.